Hi, my name is Laura Sarchet, and I'm the Inclusive Higher Education GA at the University of Rochester. I work with the TOUR program, Transition Opportunities at the U of R, through the Center for Community Engagement and with the Office of Disability Resources. Today, we are talking about autism spectrum disorders. The goal for today is that you will develop your understanding of the autism spectrum and identify one action step towards making your practice even more inclusive. So let's jump right in. What is autism? Before we start, I want to let you know that I am autistic. And so some of the examples that I share might be personal examples or from my experience with working with other individuals with disabilities in my profession. You'll also hear a little bit more about why I use the word autistic instead of a person with autism when I refer to myself, when we talk about person first language. If you want to know more about person first and identity first language, please check out our other videos on the CCE's YouTube channel. So let's start by saying what used to be categorized as what are now called autism spectrum disorders. So prior to 2013, there were many different categories that are now all lumped under the collective title of autism spectrum disorders. So someone might have had an autistic disorder or been diagnosed with autism. They might have been diagnosed with Asperger's, childhood dysgenerative disorder, or PDD-NOS. All four of these diagnoses no longer exist for new diagnoses. Anyone who was previously diagnosed with one of these four disorders is now considered to have autism spectrum disorders. Some people still identify with these previous diagnosis names, but now anyone who is going to be diagnosed would be diagnosed as someone with an autism spectrum disorder as this larger umbrella term. Some related disorders are classified as social communication disorders, and these are very similar to autism spectrum disorders, but do not have some of the repetitive and stereotypical behaviors that we'll talk about more in the later slides. Before we go on to specific diagnostic criteria, I'd like to mention that this word disorder is part of what we call the medical model of disability. So the medical model is just that with the DSM-5, the Diagnostic Statistical Manual from the American Psychiatric Association, that is looking at something from a medical perspective and that the person has perhaps deficits or perhaps needs that are different from what is considered typical. One other way to look at disability is through the social model of disability. And this is looking at the way that the environment is structured. And that's why access is difficult for people who have disabilities. It's not because of their differences, it's because of access to the environment. So you might hear me say words like neurodiverse, which is another way of saying someone who has a brain difference or a difference in the way that they think. It's another way of saying someone has a disability, but in a more inclusive way that looks at it from the social model instead of the medical model. So when talking about myself, if I were to look at it from the medical model, I have a disorder, I'm autistic, and I have a lot of challenges that are presented because of my autism. If I look at it from the social model of disability, I am neurodiverse, I'm autistic, and I have difficult with some situations because the world is created for neurotypical people who are in the majority rather than people who communicate the way that I communicate because of my autism. So I just want to preface this presentation by saying we're looking at the Diagnostic and Statistical Manual criteria. So I will be giving specific criteria for autism spectrum disorders in kind of that medical deficit model, but we also want to look more at the social model. So I go more in depth than that in some of the other videos through our office. So there are 7 criteria for being classified as someone with autism. Someone has to have all three areas of the social criteria and at least 2 of the 4 restrictive and repetitive patterns criteria. So the first of the social communication deficits is social emotional reciprocity. This is the ability to understand and communicate clearly with other people. So it is a combination of verbal, communication, speech, nonverbal, and cognitive skills that allows someone to make connections and understand and communicate expressively with someone else. So this is one difficulty that individuals with autism have. Nonverbal communication is the second social communication criteria for someone with autism. So this involves a difficulty with reading social cues, reading gestures, reading facial expressions. So for example, someone might not pick up on a nonverbal signal and might not notice when someone is feeling upset or feeling excited or feeling nervous. So often communicating with clear verbal communication and also providing visuals can be really helpful for this as well. So if someone uses pictures, that can be helpful for explaining emotions too, rather than looking at the unique way every single person shows emotion on their face. The third social communication criteria is developing, maintaining, and understanding relationships. This can be difficult for individuals with autism because of the other two social communication needs. So following up on relationships, knowing what the expectations are, and maintaining those connections can be really challenging. So sometimes individuals with autism might have a very smaller number of very close friends rather than a large network, because it's easier to maintain some of those relationships. Now, in the restrictive and repetitive patterns, an individual only needs to have 2 out of these 4 criteria in order to be diagnosed, unlike all 3 of the social communication needs. So the first restrictive and repetitive pattern that you might see in someone with autism is stereotyped or repetitive movements or speech. This can also be called stimming, and it might be a behavior that is motion, it might be a verbal behavior. So someone who perhaps flaps their hands or has a specific verbal phrase that they say over and over again. For example, I know that when I get really nervous, I start to verbally stim and might interrupt people with the first thing that pops into my head. And that's just an example of that repetitive speech. So this can look a whole bunch of different ways. It can be, like I said, verbal or physical. It can be moving something back and forth, maybe tapping a body part or tapping an object, or touching a certain object in a room, maybe a certain number of times for something. And again, those are examples of what is sometimes called stimming. And this is, in the autistic community, we often talk about this as, it's not a negative thing, it's often a way to self-regulate. So if you see someone who's engaging in stereotyped or repetitive behaviors, it might be that they're trying to regulate their own emotions or their sensory system. Sameness, rituals, and routines are another important criteria for someone with autism. One of the 4 that they can have 2 out of those 4, maybe 3 or 4 to be diagnosed. And routines and rituals can often be really, really helpful for individuals with autism. The sameness, the piece that makes this a deficit or a need, is that when something is different from the normal routine, it can cause a lot of distress. So for example, you might have a morning routine where a certain order, there's a certain number of things that you do every morning in the same order. Well, if one of those things isn't available, that can cause a lot of distress, and it can be hard to regulate and come back to baseline after those interruptions. This can also be challenging if someone is expecting something to happen later in the day and there's an unexpected change to the schedule. So it's really helpful to let individuals know when there's going to be a change, let them know ahead of time and with as much notice as possible. Restricted or fixated interests, these are sometimes called special interests, and these also can be a wide variety. Sometimes they're physical objects, or a topic is really common. So someone might have a special interest in something that might be deemed age appropriate or gender appropriate, depending on those confining terms. So we might not notice this. For example, a young child might be really interested in trains. And so they, that might seem pretty typical when they're in preschool, when they're in kindergarten, but then when they're in high school, if they still have that same special interest, sometimes special interests change, sometimes they remain the same throughout a large period of someone's life. But if someone gets to high school and they have that special interest, that might be regarded as a little bit more atypical. So sometimes it's difficult to notice if someone has special interests. For example, one of my special interests is baking. And that's, really common for a lot of people to do around the holidays or around celebrations. But what makes it a special interest is that I'm constantly trying to talk about it, and I might do it excessively. So if there's no need for more baked goods, I might still be baking because I'm really interested in it. So that's kind of an example for you. The last restrictive and repetitive patterns need is sensory responsiveness. Many individuals on the autism spectrum have sensory needs, and they might be over responsive or under responsive in any variety of the senses. So there are 8 senses when we're talking about our sensory system. There's the traditional 5: sight, sound, smell, taste, and touch. There's also vestibular, proprioceptive, and interoceptive. Vestibular is our sense of balance and where we are in space. Proprioceptive is our relationship of where our body is to ourselves. So somebody might have trouble, like they might run into things a lot or trip over things. And interoceptive is the sense of what our internal body is doing. So it's, am I hungry? Do I need to go to the bathroom? Is my temperature regulated? So all 8 of these senses, someone can be hypersensitive to, or they might be hyposensitive to, so they might not notice changes in those senses. So this can look a variety of ways. Someone with autism might be very sensitive to light or sound, and like sudden noises might really bother someone. They might also, on the flip side, be hyposensitive to noise, and maybe they don't notice that they're speaking very loudly. Someone might always think that they're hungry, even if they're physically not needing food. They might have that interoceptive sense is kind of difficult. Someone might be sensitive to touch, or they might crave touch. And so occupational therapy is really helpful for a lot of individuals with autism in kind of addressing how to regulate some of these sensory needs. One thing I want to say about the diagnostic criteria is just to touch on that there are varying degrees of severity based on both the social communication needs and the restrictive and repetitive patterns of behavior. So someone might be classified as needing support, needing significant support. And then there's also, when someone is diagnosed with autism, they are also evaluated for intellectual disability, accompanying language impairment, and then it's evaluated about whether or not this diagnosis of autism is associated with something else as well. So just a little bit of background for you. If you're interested in this, I'm happy to talk more about diagnostic criteria with you as well, but just a little overview. So right now, as of 2020, 1 in 54 individuals are diagnosed with autism. So this has increased over the course of decades. And this could be because we're getting better at noticing when someone should be evaluated for having autism. And as you can see, the prevalence in males is significantly higher than the prevalence in females. This is because most of what we know about autism is based on males, and the criteria and characteristics were originally created for what it was at the time. Autism was called autistic syndrome in boys. So females are not as likely to get diagnosed because there are differences in development. And what we know about autism is based on these criteria as viewed in boys with autism. So this number, this 1 in 54, is kind of a larger prevalence than it was in previous years, because we're starting to get better at diagnosing autism. We're starting to know what some of the earlier signs are. But as you can see, there's still many more males are diagnosed with autism than females are. Something interesting about that gender difference is when you look at development of social skills, and particularly a friendship questionnaire this study did, the bottom line is, the black line is individuals with autism spectrum disorders, and it shows the skills of males with autism spectrum disorders and females with autism spectrum disorders. The top line, the dashed line, is individuals without autism, but you can see that the triangle that indicates males without autism is at the same level as the circle that is girls with autism. So, and this is for younger students. It's often not noticed that female has autism because girls do develop some of those social skills a little bit earlier than boys do in typical development. So we see this with this study that could be a reason why many girls are not diagnosed until later in life. Another discrepancy that I want to talk about is diagnosis in race. So this is the first time in 2020 that this updated prevalence rate was made. This is the first time that Black and white children are diagnosed at the same rate. Typically, there were disparities in diagnosis. Children of color might have been diagnosed with an emotional disability or another disability. There's, access needs because of structural racism that deal with how families of color are able to get into diagnosis systems. Still, though, Hispanic individuals are underreported, underdiagnosed, and Black and brown children are still identified later in life, maybe even in adulthood, rather than white children are typically diagnosed much earlier. So there are still some of those issues with our racial structures in the United States that show up in our diagnosis numbers. So earlier you heard me mention person first versus identity first language. So in the past, we as a society have used negative disability first language to talk about people with disabilities. So disability first language is saying something like a disabled person or a wheelchair bound person. Now we've shifted to try to talk about people first. So instead of saying a disabled person, we would say a person with a disability. So similarly, we could say a person with autism or a student with autism or a student on the autism spectrum. Some autistic individuals prefer to use identity first language, which is claiming autism as part of their identity. So for example, I use the phrase that I'm autistic or I'm an autistic person or an autistic self-advocate because I know that I would not be myself if I didn't have autism. I can't separate myself from autism, and it's part of what makes me who I am. And I view that as a really positive thing, in addition to the challenges it presents. So individuals on the autism spectrum might prefer person first or identity first language. If you're not sure, you should use person first language. But if an individual asks you to refer to them with identity first language, now you might know why. So again, this is really an individual preference. Our default to be respectful to people with disabilities is to use person first language, but then it's always okay to ask someone how they like to be identified too. And the most important thing is that we're looking at everyone individually. So the kind of language we should use, most importantly, is to call someone by their name and to talk about them, and include them. And that brings me to what this means for our classroom. So in the classroom, if someone is not acquiring skills or learning the content or accessing learning in the way that we anticipate or we have identified with our learning goals, we need to change our instruction. So this is looking at disability through a social model, that it's the environment that creates access difficulties. So we can shape our environment to be more accessible and inclusive for individuals with autism and other disabilities. And this makes things better for everyone, not just people with disabilities. So structure is really helpful, having a logical sequence, focusing on goals, clear and direct communication and instruction, and then generalization. If we teach something in one setting, we might also have to teach how to do it in another setting, because generalization isn't always automatic. So how does this apply to the University of Rochester? So as of fall 2021, we have 45 students on our campus registered with autism spectrum disorders. And we have 873 students total registered with the Office of Disability Resources. Some of these students receive accommodations in their classes. Some of them are just registered as a student with a disability. However, I do want to point out that our number of students with autism spectrum disorders at 45 is just the number of students who are registered with the Office of Disability Resources. So some individuals with autism are really strong in the classroom, really strong on the college campus, so they might not need accommodations, so they might not be registered with our office. And some individuals are still in the process of getting diagnosed. Like many individuals with autism, they might not have a diagnosis when they're in college, and might not learn that until later in life. So if someone would like to receive accommodations through the Office of Disability Resources, they can reach out to us at our website, and there's a way to apply and provide documentation. And then individually, we look at what needs a person has, and then we work with them to provide the appropriate accommodations for the individual. And the Office of Disability Resources helps students to advocate to the professors and to faculty and staff and accessing the campus in an inclusive way that is individualized for each person. So if you are interested in being registered with the Office of Disability Resource, or you have questions about disability, or you're wondering how to include individuals with disability, please reach out to us through our website, rochester.edu/college/disability. You can also reach me directly at my email at ihega@rochester.edu. Thank you so much.